Welcome to Heart Failure Unfiltered. My name is Nick Hartshorne-Evans and I'm the founder and CEO of the Pumping Marvellous Foundation, the UK's heart failure charity. Today, we will be discussing whether we have a vision for heart failure in 2030, a podcast about heart failure and why the simplest ideas often save the most lives. This podcast asks one question over and over again. What does heart failure look like in 2030? Because if we don't know where it's all going, where are we going? Good afternoon, and my name is Nick Hartshorne-Evans, and I've got some amazing guests with me in the Liverpool podcast centre. It's a really nice podcast room. Makes you feel, it's lovely and warm. It's very cold outside. So anyway, we've got...
Hello, I'm Claire Taylor. I'm a GP in the NHS and Professor of General Practice at the University of Birmingham.
Hi everyone, Rajiv Sankanaran. I'm a heart failure cardiologist in Liverpool.
Hi, Fozia Ahmed, heart failure cardiologist, Manchester.
So, are we... I'm saying heart failure in 2030. That's what the sort of premise of the question around the podcast title is. We're in 2026. We're closer to 2030 than we were when we had COVID in 2020. That's quite frightening, actually, scary. But have we a vision for heart failure? So what does heart failure look like in 2030? Fozia?
I guess for me, it would look like right person, right diagnosis, right time, which means early diagnosis, timely treatment, which feeds into stuff that we've been discussing in other podcasts around patient awareness about what are the symptoms that mean you should go to your GP or to your healthcare practitioner and get checked out for. It means awareness within primary care and in the community about which patients should be tested and screened for heart failure. And it means timely initiation on specialist medications that are proven to improve outcomes and extend life, improve health and extend life.
I agree. But what is the next 4 years going to make a difference to that when we've all been pressing for that 15?
We know what to do. We just need to do it. So we've got all these fantastic guidelines that say we should implement, if you think about people whose heart muscle function is less than 50%, implement 4 treatments, not as fast as you can, but early and within weeks rather than months or years. And when we do that, we know that this will improve outcomes for patients. So I think for me, it means cutting that time to diagnosis, specialist initiation of medical treatment. And
so that's strong HF, isn't it?
Yeah.
Strong HF. But you said something really important there. It's not as fast as we can, but it's as fast as the patient.
Yeah, everything should be measured. It should be a careful, methodical approach. We should be doing it safely. So we check renal, kidney function, we check patients' blood pressures, and we ensure that they're tolerating the medication as we gradually increase it. It's not about rushing to treatment or doing things as quickly as possible, but it's about doing them judiciously. And we know that actually these treatments can be implemented, all 4 therapies, for the majority of patients within 4 to 6 weeks and optimised. There are other patients in whom, because of low blood pressure or because their kidney function is a bit more precarious, we would go slower. So it's using your clinical judgment to do that. But I think the key thing is more people diagnosed with heart failure, fewer undiagnosed cases, and everyone on the right treatment.
But doesn't strong HF, so that accelerated up titration, up medicating of the prognostically valuable medication, in other words, the life-lengthening medications, that requires us to monitor and measure that before we do it, though, doesn't it? And is the NT-proBNP, maybe I'm asking a question that you may not be able to answer.
No, go for it.
But is NT-proBNP, because that was one of the cornerstones of monitoring that up titration of the medications, is that being used?
I don't think we need to. So NT-proBNP was used.
That's a simple blood test, by the way.
Yeah, sorry.
If you'd heard any other podcasts, that's about can it be?
Yeah, so the heart hormone blood test is mission critical for diagnosis. But once you've got a diagnosis, what the next most important step is to treat that condition. So I don't think we're necessarily in the real world setting need to use NT-proBNP for titration of medications. We just simply use the kidney function, the blood pressure. So it's about removing the obstacles and barriers and doing things in a streamlined way. I think the single messaging coming out of Strong HF is we don't need to worship at the altar of go slow, start low and go slow.
Which is what I was always.
Yeah, the evidence tells us that for the vast majority of patients where blood pressure and kidney function are stable, we can achieve optimal treatment within weeks, not years.
So is this about treating the brown horses?
You're going to have to expand that one for me.
Well, what I was talking about in terms of the brown, when I was diagnosed, I was the zebra in the pack of brown horses. It's about treating the majority with that mindset, but some people won't be able to do it.
Exactly that. And to use a clumsy term to say, for the majority of people with common garden variety types of heart failure, the 90%, we can use this one pathway where you'll be tested, treated, diagnosed very quickly. There are a small group of patients in whom we have to take a different approach. But that's the whole point of getting specialist review. And by just moving, in an earlier podcast, Claire was talking about GPs primary care being the front door. And I was sat there thinking, actually, that means we're sitting back of house. And what this is about is moving that back door closer to the front door. So you're doing everything more efficiently. If you think about business and practice, it's about lean systems. It's about meeting the needs of your customer, your consumer. And actually to do that for patients, we need to deliver a model of care that's fit to meet their needs.
So in 2030, would it be a credible discussion saying that we just need to meet 2026 standards? Or do we need to keep adding?
I think we need to get the basics right.
Because we haven't got basics right since 2018. I mean, the three medications, it was hard enough getting people on MRAs.
So it's medications, cardiac rehab, so the simple things, if we do it right and do it, it's not about scoring a stoppage time winner. It's about ensuring that throughout the patient journey, as it were. No, you don't like that term per se, but we get the right treatments to the right people at the right time, but make sure that we get the basics right. It goes back to in 2030, if we can get the diagnosis made in a timely fashion, all these treatments, patients are not deprived of access to these treatments in a timely fashion. I think it'll go a long way. And again, going back to Strong HF, so just to add, so we're getting some real world evidence as well. So Liverpool, Swansea and St. George's, we're part of a real world evidence generating pathway. So like Fozia was saying, it's about using these tests wisely, where NT-proBNP can be used as a prognosticating a tool as well. And not as the inertia that we are prone to as clinicians, for example. We overcome that inertia, getting people onto the prognostically relevant doses a lot earlier. And the other thing which is important to remember is for any such treatments, you also need the staff in the NHS. So I think we'd like to see a 2030 where there are more heart failure nurses, more pharmacists. So those are the people who can deliver these treatments, start these treatments for the patients.
I said pharmacists are the most important,
yes.
Our most important clinician involved in HFpEF care.
Yeah.
Because unfortunately, people with preserved ejection fraction heart failure type tend to get discharged back to their GP without going through a heart failure specialist MD multidisciplinary team, where you have the specialist who then up titrate, because that's how it happens. But I would challenge what we've just been talking about. That what about patients? What about self-management? What about enabling people? Oh God, that's a bit technical, isn't it? Enabling. What about helping people to better manage their own condition, therefore making the appropriate right decisions at the right time? I remember my heart failure nurse said to me, and this was way back in the ancient Greek mythology period, that basically if you could get somebody who could really understand and recognize their symptoms, and this was before all the special stuff around like triage HF, but if you could get them to understand that, and through their self-monitoring, they could really affect how their care curve worked out. That really we didn't need this telemedicine that appeared in 2011. 2010 or whenever. So self-management, Claire, isn't that something that we should be focusing on? So it's a bit of a bias for me, that, but I think I've got to throw it in there.
Yeah, and I think, the patient is absolutely critical to this. And there has been a real shift in mindset from we as clinicians doing things to patients partnership. And I think it needs to go a step further. The patient is the person living, experiencing their condition. They should be central and in control of the management. And that's in terms of diagnosis and treatment. And I think just to go back to your question about 2030, I've been doing heart failure diagnosis research for over 15 years. And I think this is the most exciting and the most positive I have ever felt, that we can truly change the trajectory of heart failure. So our research shows that heart failure outcomes have barely improved in the last 20 years, looking at large GP data sets. But I think we can really change that in the next 4 to 5 years. And I think there's 2 reasons for that. I think firstly, symptom awareness. So we came up with BEAT, the acronym, in Birmingham in 2018. It's taken a while for us to get...
You remember that hotel meeting room with all those patients? And
yeah. And we all sat around and said, I can't believe it's been that long, crackers, 8 years. But we've been talking about it, and we've got T-shirts and hoodies. But I think over that time, what we've seen is that there is a true need to raise awareness of heart failure, to raise the profile of heart failure. And the only way we're going to achieve earlier diagnosis is for everybody to be BEAT aware. So breathless, exhausted, ankle swelling, time for a simple blood test, a natriuretic peptide test. And that's the absolute key to them receiving the life-saving treatments. And I think we are seeing BEAT taking off through your brilliant campaign, through Pumping Marvellous. We've had approach from Canada saying we've seen BEAT, we want to do BEAT in Canada, we did FAST for stroke. And that's just absolutely brilliant, because this is a global issue, that heart failure is diagnosed too late and outcomes are poor when they don't need to be.
How many people? 64 million people around the world, probably quite conservative.
Yeah.
That's an underestimate as well.
Huge numbers. So I think BEAT is really gaining traction. We're getting the messaging out there. We need to keep doing that amongst the public, amongst communities, amongst healthcare. So people think, could this be heart failure, and do the simple blood test, which then leads on to everything else, echo, specialist assessment, treatment. I think the second reason I'm so optimistic is I was recently on the NICE Chronic Heart Failure Guideline Committee, and we now have, for the first time, as you said, Nick, treatments for across the ejection fraction. So we know that the 4 pillars, so ACE inhibitors, beta blockers, MRAs, SGLT2s, are effective in people with heart failure with reduced or mildly reduced ejection fraction. But now we have the 2 pillars, the SGLT2s and the MRAs, which we can offer to patients with heart failure with preserved ejection fraction. So for the first time, we've got treatment options and cardiac rehab, again, across the ejection fraction. So if we get this diagnosis right, there's so much we can offer patients, and patients can be enabled to be central and part of this. So I want patients to be saying, why aren't I on the 4 pillars? And in the NICE guideline, it's very clear. You don't need to optimize one pillar and then start the next. We need to be starting several drugs, not 4 in the same appointment. But we need to be getting on with this, as Fozia said. It shouldn't be taking months to years to get people on these, life-saving treatments. And I think the patients can be central and part of that. So, I remain optimistic, and we'll have to meet again in 2030 and see how far we've got. But I think it'll be a long way.
What are we still doing now that probably won't exist in 2030?
I think rather than that, what I'd like to see is...
Is that an answer to my question? Or?
Yeah, no, it's it's that in a different way. It's an answer. But so we come up with solutions. So BEAT's a lovely solution. It's an innovation. This BEAT to treat, bringing diagnosis to treatment within 60 minutes, what's months to weeks. But what we don't want to see is that these remain as stopgap innovations which happen in pockets of the country and the world. We want them to be adopted as a part of mainstream.
Why do you think it's so difficult to get stuff adopted? Is it because of conflicting ideas? It's not my castle, so I'm not going to be involved in it. What is it? Sorry, it's an on-the-spot hand grenade question.
It's a tough question to answer. I think to an extent it is a safety first type approach. What we used to think it's safety first. If there are guidelines and there've been guidelines for decades, we think that's the right approach.
So we use the existing processes to analyze innovations moving at speed, so therefore we slow it all down again.
So sometimes there's, like Fawzia was rightly mentioning, guidelines are guidelines. They offer a guide. They may not necessarily evolve with the speed that is necessary, especially with the burgeoning condition like heart failure, with lots of people getting diagnosed. So it's about making sure that we evolve and we be proactive, not reactive. And that's the important bit. And when we demonstrated innovation that's tested, it's evidence-based. It's about trying to convince the commissioners, the people who hold the purse strings, to ensure that these get adopted into the mainstream pathways. And that's the bit that I'd like to see in 2030, that we're not talking about these as innovations. We're reflecting on these that we have contributed, hopefully, to bring them into the pathways.
One of the big things is... I think it was a piece of research that we got involved in Lancaster University in 2022, which is about the conversation around heart failure versus cancer, basically, but it looked at dementia. And not that I use ChatGPT all the time, but I did ask the question, why is cancer more well-known than heart failure? And one of the things that I actually came up with was, and it was exactly what was sort of came out of the research, was that we over-medicalise it. So awareness is over-medicalised. We think that everybody talks our language.
And about heart failure now? Or just in general?
No, in heart failure. Okay. In heart failure. And cancer is very much an emotional, we're going to beat it, we're going to do that. But also, it did also include the mortality angle. But heart failure is very much... And I think we need to change the way we talk about it. And as a patient charity in the UK... it's very important that we bring those patient insights. I think voices isn't enough. I think that's very like your patient voice. The patient insights that change and influence and implement and use it as an implementable tool. I got that through, implementable tool, to add value into decision-making processes. I think I went a little bit off piece there, but sorry.
It's sort of resistance to change, I think, isn't it? That's the other thing,
Yeah, I think if I go back to what you asked us at the question at the start, what's our vision for 2030? I guess the vision is for every patient to have a diagnosis, have correct treatment. But I think we need to create a system that is future-proof. Technology has not stood still, and neither should healthcare. We should be delivering technology or using technology. If you think about it, in any company, any business, in the NHS, our biggest asset is our workforce. And if we give our workforce the technology that enables them to speed up time to diagnosis, it allows them to spend more time direct with patients rather than doing administrative tasks. So I think the vision for the future is that we use the tools that are available right now to radically change the way that we deliver care for people in the future. But perhaps the challenge for us is to deliver the care of the future now. So what we want to see in 2030, there's absolutely nothing stopping us delivering that now, because the tools already exist. It's hesitancy and uncertainty about whether or not we should do things differently to how we've always done it.
Here's one for you. Who needs to be braver to make the vision real? Does it have to be Nick? That's hanging in the air, that one.
It can't be Nick, because there's only one of you and there's a whole healthcare system to deliver this. So I think we can't be dependent on you being here, if that makes sense.
Chief?
Yeah, I think it has to be, it has to come from clinicians and patients, isn't it? We've seen how Pumping Marvellous as a patient-led charity come up with a lot of innovative solutions. And that's based on the stories of the patients.
Yeah, we did a session at an international conference in Washington, D.C. that is absolutely inclusive of patients. And there were probably 5 or 6 researchers turned up to our session, and all the rest were patients. Whereas every other session, it was full of researchers. Yeah, so why aren't they interested?
And especially if the if the message it's evidence based, it's demonstrating impact and patient benefits. So I can't see why the system at large and clinicians don't come along on this journey and bandwagon, as it were, where we're improving things, and that's the bit I'd like to see, that more clinicians come along and share the vision.
Claire?
Yeah, I think we always need a Nick, and we need somebody who can champion and keep saying in every room that you're invited into, heart failure is important. Beat is a way we can change the trajectory for people with heart failure. And I think we need to learn from other successful campaigns, particularly FAST. So speaking to Professor Gary Ford in Oxford, who created FAST, who's seen FAST go round the world over the last 20 years.
He didn't realise that 4 letters would actually make a difference. He thought probably 3, but I didn't believe 4 did, but it has.
Yeah, I mean, they came up with that to recognise stroke symptoms, initially for paramedics, to get them to the right stroke centre to get treatment. But, FAST has organically and naturally spread around the world and directly impacted patient outcomes. And I think we can really do the same with Beat. So we need the initial noise and voice that we all make with our t-shirts and things, but we need people to then become believers. So the people who contacted us from Canada, they're genuinely interested and want to change the trajectory in heart failure, like they did in FAST, using FAST for stroke. And there's real opportunities here for us to spread the word, but it does involve everybody working together, as you've both said. We tend to work in silos: primary care, secondary care, patients, industry, but actually it's everybody's business to improve things, because patients deserve better in terms of quality of life, length of life. Hospital services are under huge strain because of these late diagnoses of heart failure, people, emergency admissions, when we can diagnose people earlier with this simple blood test and investigations in the community. So I think it's beholden on all of us to try and improve things by working together, to have this sort of shared message that I think we can hopefully do with Beat, that we've seen success so far, but we need to take it bigger, wider, get the messaging out there, and that's hard when it's a noisy world with lots of information going on.
I think simple, but I don't think I could have summed that up, the discussion we've just had, any better than you have. I think it's brought us right down to, fundamentally, if we know what we know works in 2026, that wouldn't be a bad thing in 2030. But if we don't define the future heart failure care, who will?